Thanks, Pam, and thanks for your efforts in putting together this panel. It actually enabled me to meet a lot of people from different disciplines that I have never met before, so it's kind of interesting to be the chair of a session where you don't know anybody on this, but they all turn out to be very talented and productive people, and I'm looking forward to what we're going to hear from this interaction. Some of you who are clinicians may know that the American Psychiatric Association regularly updates, just like you update Microsoft Word, you updates the classification of mental illness. And unfortunately, in mental illness, we don't have any biomarkers yet. That's the gold standard that we're really looking for. But we do have improved interview-based methods of defining mental illness. And so it was my job to chair the committee this time on substance use disorders. And that just came out in 2013. And we made a few changes because of the pharmacology of addicting drugs. But the really big changes had to do with the fact that addiction at its core is activation, reliable activation of the reward system in such a way that it produces very intense learning that you can't just erase and turn off. And addiction is a very troubling thing, and it turns out that there are some behaviors that are addicting without having a drug. And the first one that we studied and reviewed and included was gambling disorder. And so gambling is now lumped with the addictions, even though we don't have a reliable medication, although we do have some that do some pretty good benefits. But we added gambling. And then once we did that, we looked around at other things, and there was a big pressure to add sex addiction, work addiction, and food addiction. But for various reasons, those did not make it. But one that made it into at least Section 3 to encourage research is what is often called internet addiction. And so that's what we're going to be talking about for the next hour or so here. And we made some suggestions when DSM-5 came out as to how it might be defined, but we're hoping that people will get interested and it will be better defined and studied more, and this is how we make progress. And we are also hoping that there'll be a biomarker as well for that, because in fact we do have brain imaging techniques that do show some fairly specific changes in brain reactivity to internet stimuli. So you're going to hear about some of this in the next few talks. So I want to go through the list of people here. I think they're going to be looking at this from different perspectives, and this is important because the field, the clinical field, is already there. You could go and Google or open the telephone book for treatment of internet addiction almost anywhere in the United States, and then it turns out to be very common in some other countries, such as China, Korea, mostly Asian countries. And so it's already there, even though it does not exist yet in the DSM-5. So you're going to hear from some of the people who are coping with this and as to where it stands right now. And what's going to happen is we won't have to wait 14 years to add it. There is a committee that's already reviewing new data. So as we get new data on depression, anxiety disorders, and addictive behaviors, we'll add them and add new criteria to the next iteration of the DSM. So I'm going to go ahead and introduce each panelist, and pretty much in the order as in your program, except that Kimberly Young is going to be the first presenter from Bonaventure University, and then she'll be followed by Doug Gentile. But Kimberly, could you come up and present your perspective on this problem of what is often called internet addiction.
We don't have enough seats. Is there, I have one slide I was going to show, so yeah, I'm going to explain that in a minute. First, thank you for having me here to speak to you. As some of you know, I started studying internet addiction in 1995. It was shortly after a friend of mine's husband was addicted to AOL chat rooms. It was a time when it was still $2.95 an hour, and he was spending 40, 50, 60 hours a week online. And not only did this create a financial burden, but their marriage ended in divorce when he started meeting women in online chat rooms. Now, 20 years ago, nobody was really looking at this, I think, as a serious clinical problem. But it made me wonder if people could get addicted to the internet in the same way we talk about drugs, alcohol, and sex. So I posted a small survey online taking the same clinical criteria for pathological gambling, and I substituted the word internet, and it's actually more commonly known as the Internet Addiction Diagnostic Questionnaire if people have followed my research over the years. But anyway, you know, I posted this online not really thinking about what I was going to find. Back when I probably had 2 emails a month, I had something like 50 emails the next morning from people telling me how they lost their jobs and their marriages because of their internet addiction, or students across the country having problems with the very tool that they were being encouraged to use. So I expanded my survey, and I really just wanted to understand what people were doing online for so long. By 1996, I had presented a paper at the American Psychological Association, I believe the first in the community, to look at this as a problem. And then by 1998, I took my studies and I put it into a book called Caught in the Net. Now, this wasn't even a field. I would say there were individual researchers. There was David Greenfield in Connecticut. There was Marissa Hecht-Ozark at Harvard studying this. There was Al Cooper at Stanford. There was Mark Griffiths in the UK. But it didn't become a field until the 2000s when Korea, China, and Taiwan started really recognizing this as an epidemic, a serious problem. Research poured out. I know Professor Ko is here to talk more about Korea, but you know, it seemed like all of a sudden there was more research trying to understand comorbidity, understanding what the risk factors were, looking at treatment. In 2006, I remember Beijing opened up its first treatment center, and that has been the topic of Web Junkies, one of the more popular documentaries on this topic. So anyway, you know, the field continued to grow. Also in the 20-year span of this, you know, the technology changed. You know, Facebook and Twitter became more popularized and were invented, for that matter. There was more reasons for us to go online. Digital life changed. And also what happened in 2010, the first iPad came to market. And now everybody, you look around, has a phablet, a tablet, a smartphone. We have become more mobilized. We have become more digitalized. And the research continued to morph, but also is now looking at things like smartphone addiction, texting addiction, and all the new applications that were being devised were now looked at as addictions. What I perceive in this 20-year span is one of the more significant events was the first International Congress on Internet Addiction Disorders, which is what this photo is from. And you'll see Professor Ko and myself, we were keynotes. Professor Giovanni, it was held in Milan in 2014. He's in the middle of us, and Serge Thrisson from France. And you know, world leaders were brought together from the field to first talk about this in a real way and saying, what is everybody doing out there? And what was apparent to me was that America was falling behind in this issue. We did not have any government or national programs, unlike many other countries throughout Europe, Australia, and certainly in the Asian cultures. There was much more being addressed. And I'm not saying just treatment centers, but prevention programs, early childhood screening. And so what I also thought, since we're talking more about kids, some of the issues that were presented at this conference collectively in terms of digital addictions in kids were things like social problems, in terms of, you know, were kids more isolated because of screens? And what I saw, the question became how much time is too much to how young is too young. That was a big focus of a lot of the conversations I had at this conference. I think the concern was the kids were just, you know, at very early ages, like I don't know if you've even seen things like the iPad bouncy seat or the iPotty chair, but like at very young ages, we kind of accept the technology is kind of okay to use without really understanding maybe some of the long-term ramifications, or where is that balance? And so that's what I felt very interesting about this particular conference, because we really were talking about it. You started realizing also this is a very global issue. It is something that has a cultural base to it. Certainly more cultures have more of a problem with it than others. And I know we'll be talking more about that later. But one of the things that also came out were reading problems in kids being, when they're quite young. You know, can they read traditional books that require a different concentration skill for traditional books that are much more linear, much more page by page, more line by line, versus the scanning and skimming and scrolling on a screen. Or a lot of the research also focused on obesity with kids, and kids just sedentary and not getting out and playing, not having any motor play and exercise. And so to that point, one of the things I've been working with is the National Obesity Foundation of Canada. They piloted the first Screen Smart school system. And it's really an innovative kind of program looking at how do you get young children to look at screen awareness. And, you know, in talking with teachers or administrators, it's a curriculum-based, grades 4 through 7. So it's talking directly to kids, raising their screen awareness, but it's a holistic program too. It's looking at diet and exercise, and I find it really where we need to be. We need to be much more about prevention and just raising awareness. It's not necessarily to call it an addiction, but to say, hey, look, how can you find a really good, balanced, healthy way of using this, and also getting out and exercising. Also, in my view, looking at teacher training, looking at identifying kids that are most at risk, looking at early childhood screening to also identify those kids most at risk. I think the other thing that we've been working on is looking directly at parents, who are really the primary caregivers of all this technology. I mean, in a large sense, they're the ones that really probably need some of the more help. I mean, I think it's much more complicated today to be a parent. And I think you need to look at much more about the technology from the time, certainly when I grew up and it didn't even exist, to the time that, you know, like I said, it's how young is too young, and the time that they're born, they can probably have access, and most young people know how to plug it in when the battery goes down, and they're just so much more sophisticated with some of these tools than their parents. So we developed the 36912 parenting guidelines, trying to look more holistically. I know there's a lot of different debates on how young is too young, whether it's age 2, age 3, and what that might look like. What we tried to do is more of a developmental lifespan approach, so that when we work with parents, you know, kids really have different technology needs in the home, and technology media, I mean that in a broad sense. So I think the biggest things I found in terms of digital addictions in kids is really working more on prevention, working more on just awareness, both with parents, teachers, school counselors, to do some testing and early interventions. And I think that's really, you know, I'm going to stop here. I know we're running late for time, so I'll just end my marks there.
Thanks, Kim. It's only fitting that you should be the first speaker, because you've been such a pioneer in this field, and we all owe you a debt for that. But next speaker is going to be Doug Gentil, who has, I really recommend his review, which I think has recently been published. You get a really good feel for the depth of the available data right now. And Doug? Thank you very much for making me French, although my Italian ancestors might be horrified by that. I'm a child psychologist. Yes, I know I look older. And I'm not a clinician, and I came to this, and really it is an honor to be here with so many of the real pioneers in both the research and clinical practice sides of this. I came to this issue out of a place of deep skepticism. Even back in the 90s, people were talking about their kids being addicted to video games, and I thought, that can't be right. I thought, all parents mean is, my kid spends a lot of time playing, and I don't understand why. But you know, an addiction means more than doing something a lot. It means doing it in a way that causes serious dysfunction. And it can't just be dysfunctional in one aspect of your life. It has to be dysfunctional in multiple aspects of your life, to the point where it's gotten so out of balance that really it's achieved some level of clinical significance and needs to need some type of intervention. And I thought, there is no way video games are having that type of effect. And so I started studying it from that more clinical standpoint, and it turns out I was wrong. In some national data I collected with Harris polls, a beautiful national sample of 1,200 kids, we find that using that fairly clinical definition, about 8% of gamers 8 to 18 would classify as addicted using that approach. The good news is, of course, that's 92% aren't having problems. They're playing games and keeping their lives in balance. But that's not a small number. If there are 40 million children
between the ages, or up to 18 in the US, and 92% of the game, and 8% of them are taking damage from it. That's over 3 million children today are taking serious damage to their lives because of the way they're playing. So I've come to accept that this is a real issue. I've been forced by my data to accept that. But I see my role today as really kind of trying to provide some more challenging views. And so there are 3 views that I'd like to put forward as kind of questions to consider as we hear from all of these distinguished speakers. One is there's a big debate going on about how should we define the issue. We don't even know what we're talking about. You know, is it internet? Is it about, you know, video games? Is it, you know, how many symptoms is enough? What should those symptoms be? The American Psychiatric Association in DSM-5 at least gave us guidelines. They gave us 9 symptoms. And so that's, you'd think that would have solved the problem, but no, the debate rages on. And I think really we should be thinking in terms of construct parsimony. That similar to gambling addiction or pathological gambling, a person who gambles on horses doesn't usually also play poker. The person who is addicted to poker doesn't play roulette. The person who's addicted to roulette doesn't play the slot machines. So are those 4 different disorders? Is that horse addiction and roulette addiction? No, those are all the same underlying disorder. I tend to think of it as an impulse control disorder, although I'm not a clinician, so take anything I say that has clinical relevance with a big grain of salt. But why are they considered one thing? Well, because they would be diagnosed basically the same way, by dysfunction. They probably have similar risk factors. They would probably be treated about the same way. And so rather than trying to say those are really separate disorders, you know, let's focus on the commonality. I think that's similar, at this point in time at least, to internet addiction, or to game addiction, or to internet game addiction, or to cell phone addiction, or any of these other technology addictions. There is really no strong evidence that I'm aware of that says these are clearly distinct taxons. So until, now there may become good evidence about that, but at this point I think it's more parsimonious to say, let's just treat them as all kind of different manifestations, different morphologies of the same underlying disorder. That said, we should be doing research to see when that breaks apart, because it certainly may be. There may be some distinctions that we need to make in either diagnosis or treatment, but at this point I don't think we know quite enough to be able to claim that. And I think the APA kind of fudged that by calling it internet gaming disorder. They blended them. The second view that I'd like to put forward is that there's a big debate on about how should we measure it? What's the right way to measure it? What's the right phrasing of these questions? How many items should we use? Blah, blah, blah. And I don't mean to dismiss the fact that it's useful to be clear about our definitions and useful to be clear about our measurements. But I've now studied this several different ways with several different types of measures. I know that other people have used different measures. We have measures that go from 7 items up to 20-something. Some of them are on a yes-no scale. Some are yes-no sometimes scale. Some of them are on a frequency scale. Some of them are on agreement scale. And my take on all of this evidence is they all say the same thing. No matter how I've measured it, the results look pretty much the same, which suggests to me that the construct is robust to measurement. That's actually an important thing. If we could only show that this shows up if you measure it this special way, that one special way, and every other way doesn't show the same results, then I really don't trust that that's a serious construct. But if no matter how I measure it, no matter how many items I use, no matter what type of scale I use, I keep finding the same pattern, that suggests there's something real there. And it also suggests that maybe we don't need to fight so much about which scale is the right scale. And then the third view that I'd like to challenge you with is this issue of whether it's a primary or secondary problem. I hear this often from reviewers of papers as they're rejecting my papers. And so maybe this is just reactance. But I think it's a false issue. And again, I'm not a clinician, but it strikes me that when a patient comes into your office and needs some help, you don't just need to look for what was the problem that started the ball rolling. You need to look at where is the ball today, what direction is it going, and what is providing it momentum. Because mental health disorders are comorbid. You start with one and you pick up others, and then they push each other around. And so whether or not gaming, the gaming problems started after the Depression, or whether it started before the Depression, kind of doesn't matter, at least not in clinical practice, because you have to deal with the full patient where they are. And so I think this is kind of a false issue, that just saying, well, we're not going to treat it seriously because it may be a secondary problem. To the person suffering with it, that's not going to really help them. And so I think, I think it's important. There's a serious question about, what is the pattern of comorbidity? What is the etiology? How do these things interact? That's important science. We should be doing that science. But at this point, we've only been dismissing things because we say, well, maybe it's secondary. The kid's depressed, and so they play games as a coping mechanism. Yes, that's often probably how it starts. The same way, that's how alcoholism starts. You had a hard day. You come home, you take a drink to take the edge off, and over time it builds, and it becomes a problem all on its own as well. So these are kind of views I'd like you to hold in your mind as you hopefully read our white paper, which is insanely long, about 100 pages. So it's a good, I think, synthesis of the research at this point, but also as you're hearing people today. Thank you very much.
Thanks, Doug. I just have to squeeze in a comment as chairman that, having studied addiction for most of my life, actually, the cardinal symptom that, to me, illustrates the severity is relapse. It's something that people want to stop, but they can't stop. And we have so much now neurobiological evidence that this is a brain mechanism. We have the conditioned cues that provoke release of dopamine, increased blood flow to critical areas in the brain. And so I think that as we go along, if we think more and more about the brain effects of addiction, that's how we're eventually going to get control of this problem. But anyway, we perhaps can talk more about that. David Strayer is our next speaker, and David comes from the University of Utah.
Thank you. Thank you very much for inviting me to present. I want to talk to you about what I consider to be a kind of a perfect storm. It's a perfect storm of much of what's been talked about today and yesterday about digital media in particular. This is the device that I'll be calling out, the cell phone. But with respect to the perfect storm, it's this when you bring it into the car. So what we see is probably driving is the most risky activity you do. It's the #1 source of accidental deaths for teens. So what we're seeing is teens are oftentimes the first to be bringing these devices into the car. By definition, they're novice drivers, so they really don't know how to drive very well, or they're just learning how to drive. They, again, they're some of the first adopters, and they have the highest risks of fatal crashes. If you look at the data as such as it is, about 3 out of 4 fatal crashes have some component of distractions associated with it. And what we've really been interested in is the degree to which this device basically is contributing to a lot of the distractions that are behind the wheel. So cell phones, when they first invented it, was called the car phone. And it was designed to be in the car. It was built in 1973. It plugged in. It was big. It was clunky, and you didn't carry it around. And all you could do was talk with it. But that's evolved. It's not your mother's or grandmother's phone. These devices, first of all, are ubiquitous. So there's, 321 million people in the United States, and there's 317 million cell phones. So just about everybody who can have a cell phone does have one. Clearly, little kids, hopefully below the age of 2, don't have a cell phone. But I don't know. So we're seeing that in terms of the exposure, it's high. And these phones, I mean, you can talk on them, but that's kind of quaint. In fact, actually, teens don't use it to talk. But you can talk on it. You can send texts. You can email. You can use the camera and the video. You can do internet searches, dinner reservations. it allows you to connect with social media. And when we talk about the idea of the reward circuits, one of the things is if you get a text coming in, it's very likely that it's somebody who's triggering that reward circuit, that it's some kind of social connection that's actually relevant. And that may be a heck of a lot more relevant than staying in your lane as you're driving down the road. So there's Facebook and Instagram. And actually, there's so many of these things. I've learned some of them today because it moves so fast that I don't keep up with the social media like I could. You see selfies. In fact, actually, more people have been killed with selfies this year than been killed by shark attacks. Okay. So we're connected to this stuff. There's gaming. People will game on this. And what's happening is, and there's 1.5 million apps that will work on this device. So, and I have no idea what all of them are. But the problem is that you can either bring that that cell phone in untethered and have access to it, or now all the cars, every one of the cars that you can purchase these days will allow you with Bluetooth to connect it so that your car becomes an extension of that digital interface. And so absolutely everything that's been talked about in this conference so far is something that is at play in the car when the teens are starting to drive, and it's killing kids. And I've seen lots of examples of it. In terms of the addiction, people sleep with it. Kids, I've seen teens who will sleep with it under their pillow, so if a text comes in the middle of the night, they can respond to it. A survey, this got me, a survey in the UK said 18% of people interrupt sex to address a text. I think that's probably one of the criteria that should be on the DSM. We interrupt social interactions. I do some work where I actually take the cell phones away from students to kind of look what happens when they unplug. Most of the students report phantom vibrations, that they're out, and actually usually in the wilderness where there is no, they don't have the phone, they don't have any internet connection, and 2 or 3 days in, they still feel the phone vibrating even though it's not possible because they don't have it. That's classical conditioning, and it's coarse, Pavlovian, kind of where you've got this kind of a connection that's really quite strong. Let's see, and you see various kinds of characteristics, Facebook depression, you see the Google memory, it's actually changing the way that people remember information. It also is a little different than some of the old media. So one of the questions is this just something that's just an extension of the old media? Paul actually has done some work on the attention economy and talked about how the information content of something that comes to your door in the form of to the library in terms of a book or a journal, it doesn't matter. You can access that within a couple of weeks, and it doesn't matter. A newspaper, it's kind of dated after the first day, and so there's a little shortening of the time. But by the time you get to it, email, maybe you better have, by the end of the day, you should reply. Text, if you haven't replied within about an hour, people are going, what's wrong with you? How come you haven't replied? Now that matters because if you're driving and there's a social pressure to be able to respond immediately when that comes in, it creates all kinds of problems. So we're seeing that the information value of cell phones has a very short half-life relative to most of the other media. And we also think that the vibration, that little pinging that you get is triggering this reward circuit that's triggering and releasing dopamine. And so, you know, in a sense, we think it really is this perfect storm, this hyperconnectivity that is basically driving it. Not everyone's equally kind of addicted, if you will, to the cell phone. So when we've done studies looking at individual differences, it turns out that people who tend to use the phone a lot and are high in media multitasking, as we saw yesterday, are high in impulsivity, high in sensation seeking, and have low working memory capacity. So it's not really the person you would want if someone's going to be on the cell phone to be driving. So we see that this hyperactivity, if you do have people unplug, it can actually tend to have restorative effects. So kind of the flip side of over-connecting with college students is if you pull the cell phones away from them so that they can't use them for 3 or 4 days, we see increases in working memory capacity scores. We see increases in higher order cognitive functions like creative problem solving and so forth. So there are some kind of longer term negative consequences associated with this hyperconnectivity. But back to the discussion about driving, it is driving is the most risky activity we do. Teens are are one of the groups that's most likely to be using some of this newer technology. And that we see lots of crashes that are either directly linked to multitasking or directly linked to distractions that would include multitasking. Many people actually, many people actually think, if you talk to them, that they don't really understand the nature of the distractions and what's the problem. So they'll think if I use a hands-free cell phone, I'll be safer. But that's attributing a lot of attention to the hand. It's really what's happening in terms of the mind. There's no difference between handheld and hands-free cell phones, even though about 13 states make a distinction legally between that. Many also think if it's in the car, the auto manufacturer certainly must have tested it to make sure that it's safe. And I can assure you that, well, some groups do some testing, but there's a lot of groups who they don't even have any human factors group in the process. It's just rapid development of engineering that goes into the car and in many cases is very distracting. Some of the systems like CarPlay is supposed to provide a relatively limited, restricted set of activities from your smartphone that can be done by the driver, but a clever teenager can easily bypass those. And so again, anything that your smartphone can do, your teen's likely to do. You also might hope that the federal government or regulatory agencies might somehow oversee and step in. Sadly, no. The federal agencies have really been kind of hemmed in terms of that. First of all the regulations in terms of distraction are done state by state, and so there's this patchwork quilt that doesn't seem to make any sense. And what we're seeing is that if you watched any TV recently, you may have noticed that when they're advertising new vehicles, it's not 0 to 60 in 3 seconds, and it's not some kind of safety rating, and it's not some kind of fuel efficiency. They don't even talk about that anymore. It's all about the electronics in the car, and they've got advertisements showing teens pushing buttons and interacting with Facebook while they're driving. So I actually think that what we're seeing is that if anything, the storm we haven't kind of hit the apex. It's getting worse. And so to kind of quote Deb Hersman from the National Transportation Safety Board, it's the Wild West out there, and it's likely to become more of a problem and more of a problem for the teens. So with that.
Thank you very much. Everybody is keeping to the time so well that I think there will be time at the end for some general discussion, so you have a chance to discuss some of the points that David just made. So our next speaker is Megan Moreno from Seattle Children's Hospital. No, Stephanie. Stephanie Brown from the Addiction Institute. Right. Stephanie, thank you.
Thank you. Hello, I could be Megan. That would be fine. Thank you, Pam. Thanks to all of you for this day. Like many others, I want to say I'm not against technology. My emphasis is on fast. My emphasis on the speed that is now what I call the central organizing principle in our culture. We are addicted to going faster and faster and faster. And we have changed our meanings, we've changed our behaviors in order to rationalize and allow a culture that is chronically, traumatically out of control for many, many people. Internet addiction is a piece of this. But I would like us to also expand our framework to a broader definition of what is addiction, which I look at as an attachment disorder. I am of the psychoanalytic, psychodynamic frame, and I like to look at addiction as getting hooked, just like occurs in human attachment. Addiction is much more than behavior. It includes behavior, absolutely, and that's what we see typically, but it is also a change and alteration in cognitive processing, turning to a dominance of defensive operations, a turn toward pathological thinking operations, and addiction is all about affect, how we feel. What I want to do is describe for you the experience of a culture that is out of control. I came upon this in the 1990s. I was in the midst of a major research study on the alcoholic family, looking to define what's an environment in a family system that is characterized by parental loss of control. What is that like, and what's the impact on children of living with parents who are chronically out of control? And not even chronically, actually. I don't want to state this as an extreme. Alcoholic families are often highly functional. And as I was doing this research in the 90s, I live in Silicon Valley. And I was looking around me. And one day I said, you know, the same dynamics as occur in an alcoholic family are occurring around me in my culture that was becoming identified with speed, with technology, definitely. But I also saw and was living in this environment of changing values, changing attitudes, changing beliefs, okay, all supporting going faster and faster as the new definition of success. Just like the high of a drinking binge or a gambling run, the exciting promise of never-ending innovation, invention, startup, stock options, never-ending success had drawn society into a new chronic state of loss of control. Society, in my view, had become addicted to speed by the year 2000. Not the drug we call speed, but the insatiable, unstoppable drive to live faster and faster. Just like an alcoholic family settles into rationalization and denial that the family is out of control, society was altering values, norms, creating new reasons to legitimize cultural chaos and loss of control. What I'm saying here will be one of my major conclusions, how we need to expand and understand cultural pressures as well as parental behavior and its impact on children today. Okay? I think we cannot single out children and expect them to be able to develop self-control in a family system and a culture that is legitimizing and valuing constant acting on impulse, constant sense of instant gratification, and that doesn't value slowing down, doesn't value self-reflection. We are sacrificing looking inward, contemplation, for faster and faster. Now, what is speed, actually? Speed is fast. It's rapid pace, rhythm, feel, tone, mood, movement. Speed is intensity and urge to act now. That urge turns into internal urgency to have it now and to have it again. The repetition compulsion, the need to go, the need to check, the need to press. Blow on the dice like gambling, down that shot and press send. Speed is pressure. It's a rush to a future. We are finished with the now instantaneously. Progress equals instant results, instant outcome. There is no time to pause to savor anything. There's only progress, only forward motion now, or there's failure. There are 4 key organizing factors that I can very globally use to define societal addiction, and they are also present in alcohol addiction and all the other kinds of addiction that we're now accepting. Loss of control. Behaviorally, you can't stop doing what you're doing, even though you need to stop. You're dominated by impulse, so it gets harder to delay or endure. You can't wait, you've sacrificed learning through engagement, through a human attachment bond that we're hearing about today, for instant reward, instant answers, and instant gratification. You've accommodated to a new norm of constant interruption, so you get anxious if you're not in constant motion. Kids have shifted from active play to passive play. We have a vicious circle now where we are causing increased anxiety that people are responding to with more button pushing, more attempts to deal with inward experience without going inward. It's the outsourcing of human responsibility, human sense of agency. Dominated by impulse, your emotions become primitive. You're prone to instant panic, anxiety, and infantile confusion and chaos, as you have no working ability to quiet yourself or regulate your emotions. This is true for adults. It's true for children as well. One consequence of the emotional dysregulation and regression to match this behavioral impulse dominance, one consequence is to diagnose the wrong problem in a sense. So many kids are getting psychiatric diagnoses for what are these problems stemming from the speeds and the pressures, and a turn to medication. Now, please don't think that I'm against diagnosis or medication, but I see its misuse. I see that we are becoming and have become what I call a medication-managed culture to treat lifestyle issues that we have created in the name of success and progress. We have become medication managed to prescribe so people can work harder, work smarter, work faster, and young children to try and get them to be able to sustain this speedy pace. I also say that we live in a business model culture. Together with medication management, we believe we can solve every problem. We believe, in addition to the loss of control, we believe that there are no limits on human beings. We should not be limited. It's in our heritage. We are entitled and we are exceptional. And I'm talking about America. Okay. Manifest destiny. I want it now, do it now, are valued affirmations today. A belief in the omnipotence of human power, a belief in human will. Okay. Human will is enormously important, and certainly we've sacrificed a lot of it through relinquishing agency. But what we do with that belief is translate it, you should be able to do anything. If you cannot work 18 hours a day and start over again for another 20 or 24, if you have to go offline, you are failing. What do we do about this? You try harder. Try harder is a mantra for our culture now and for kids who are not able to keep up. They're falling off the wagon. And the fourth factor organizing our culture is dichotomous thinking. We are a culture born to be certain about everything. To know everything, we think there's a right and a wrong, a bad and a good, and the dichotomous thinking pressures to keep this cycle going. The affect of the confusion, the fear, the panic, the terror. I can't find the answer. The cognition, the thinking that says you should be able to do this. Try harder, press the buttons more. We are on a path taking us away from relationship with ourselves internally so we can say we don't feel at all. I'm absolutely recommending that we as a culture look at what I'm describing and give placement back to the understanding of child development, human development, and attention to the importance of going inward, of self-reflection, thoughtful contemplation, as a way to help us regain regulation of an entire society. Thank you.
I'm looking forward to the discussion of that as well. Are you, oh, Megan, okay, so now, finally, here's Megan. I apologize for introducing her at the wrong time, but Megan is from Seattle Children's Hospital.
It's really been a pleasure for me to be part of this panel, and I come to this panel with the perspective of a pediatrician and from a public health perspective, and I think I also come to this panel as the kind of a new kid on the block to this area of research. I became interested in the area of research of problematic internet use from experiences in my clinic. I'm a practicing adolescent medicine physician at Seattle Children's, and I found that we would be referred patients who were referred for headaches or stomach aches or sleep problems or school failure. And after our diagnostic evaluation, what we would find is they were really wrestling with is problems of balance with internet use or video games. And ironically, what we often found would happen with these patients is that they would eventually fail out or drop out of school and be told to complete their degree online. So with a public health framework, the way that my team has approached this field of research is to start, our earliest study was a systematic review to really understand the scope and the breadth and the different language that's been used in the great science that's come before. From that systematic review, we recognized that we wanted to better understand a conceptual approach to PIU. So my team has really approached this as a problematic internet use as an umbrella term to encompass the addiction constructs and some of the other problematic use constructs. Following that study, where we developed a conceptual approach to PIU, we used that conceptual approach to develop a screening tool that we wanted to be able to be used in pediatric clinics. And so we used the conceptual approach to guide the development, the testing, and the validation of that screening tool. It's an 18-item screening tool called the Problematic and Risky Internet Use Screening Scale, or PRIUS with 2 S's. And what we're working on now is taking that 18 items and working on trying to pare it down to a 3-item screen that we can add to a lot of our routine screens that we use in pediatric clinics. So along the way, I've really benefited from the guidance and the understanding and the reading of the other literatures that are provided by the giants that you see sitting up here today. But I've also come to understand that a lot of us are using different terms, and we're publishing in different journals, and we're speaking different languages. And so some of my hope from the process of this conference and being up here today is that we'll take that next step towards a more integrated science of understanding and respecting what's come before us and understanding what we need to do to really help the youth and families today. Because despite the work that I've done, when I go to clinic next week and I sit down with the family and talk to them about that I'm worried about their internet use, they actually don't really care about the Cronbach's alpha of the scale I used. And they don't really care whether I used the correct term of IGD or PIU or internet addiction. What they want to know is, what do we do? Will it work? And will my insurance pay for it? And so I think although there is a huge surplus of internet addiction counselors and specialists in our phone books, I don't have a way of knowing whether what they do works. I don't have a literature I can draw on to be able to say there is good evidence that the treatment I'm going to recommend for you works. And that really troubles me as a provider. I think second, if we want to get to a place where insurance companies are going to pay for these types of treatments, we need to develop that evidence base to support it. And so I would make the argument that I think some of the problems we're facing in this field are ones that have a social justice angle. Because right now, my patients that are rich and have internet addiction can afford to go to the counselors and can afford to go to the treatment centers. And the patients that I have that are poor don't go. And those are the patients that fail out of school and do poorly. And so I think that to me, that's really the approach I come from is what do I do for that patient in front of me? And how do I take that science that we've all worked towards and be able to apply it to that N of 1 patient who's in front of me? Thank you so much for your attention.
I hope that we get a chance to discuss in a few minutes some of those practical issues that Megan brings up about what do you do with a patient sitting there. Now, our final speaker this morning comes to us all the way from Seoul, South Korea. You want to stay seated? That's okay. That's fine. It doesn't. We're very flexible here. Professor Young-Sam Ko is from the Internet Addiction Counseling Center in Seoul, South Korea, and he's going to be speaking to us with the help of a translator. And let me welcome you to this meeting, sir.
Thank you very much. I am Young-Sam Ko from South Korea, and I am working with the National Information Society Agency in Korea. In order to make a panel discussion more effectively, from now, Chris John is going to translate my speech.
Korea has the highest internet addiction. So as a result of that, and then Korea is known as one of the developed countries to correct internet addiction. Today, I'm going to introduce you the problems of internet addiction in our society, and then I'm going to talk about our country policy towards it. We are going to go forward a profound digital era and a digital addiction problem that continues to exist in our society. The first, in Korea, the internet addiction rate is about 7%. Right now, because of the 7% addiction rate, it has to be addressed to correct the problem. In Korea, annually we investigate the internet addiction rate. With this investigation, we create the most effective method to correct the problem. Since 2004, that we have been studying and then investigating the rate of addiction. Perhaps it is because of our efforts, the addiction rate has gone down every year. We've been also studying the smartphone addiction. And then entire population, we have about 14% of addiction rate. But the adolescent addiction rate is much higher, it's about 12.5%. And then smartphone addiction is about 30%. The smartphone addiction and the internet addiction is almost the same common problems as well as grown-ups. I will tell you about the peculiar aspects of internet addiction. For some reason, the internet addiction rate has gone down, but smartphone addiction has gone up. Secondly, the group of more vulnerable internet addiction, for example, people in poverty, unemployed people, and then also families and people who came from underdeveloped countries to Korea. And also disabled people, they have a higher rate of addiction. Thirdly, it also causes more, it alerts us to focus on addiction on smartphone more than internet addiction. The internet addiction turns into smartphone addiction. Now also we are worried about wearable internet addiction. So wearable internet addiction, Google phone and then iPhone watches, those cause more addiction, and we have to prepare more smart way. Fourthly, that the aging group of addiction has been expanded. In the past, it was limited to young kids, but now and toddlers and also even people and middle-aged people, they're falling to the group of internet addiction. Then I'll tell you about the efforts we as a Korean government are making an effort to correct this problem. The first distinction of Korean government is different than other countries. And the country itself is making an effort. And then also it is enforcing law. And then we have a graphs to talk about this one. Yeah, the cultural enforcement and also legal enforcement are also utilized. And then according to my own study, the United States and Germany is more focused by the individual and also the college-based solution. Just as Kimberly just talked about how the college is helping. That in Korea, the government itself is focusing on how to solve this issue. And recently, and in China, actually use the same method as a treating alcohol addiction as the same as internet addiction. And that is a problem because the purpose of curing internet addiction is different than alcohol addiction. The alcohol addiction is to stop the usage of alcohol, but internet addiction treatment should be considered to be in a different manner because it is controlling, not the stopping. In China, it is having different methodology compared to Korean way of handling this matter. Okay. And the background of success in Korea is that there are 8 different government bureaus are working together and making a collaborative efforts to correct this. For example, Ministry of IT Planning and the Ministry of Culture and the Ministry of Education, Ministry of Gender Equality and Family, and the Ministry of Health and Welfare, and also Department of Defense and the Department of Justice are all involved and to work together, making a collaborative effort. And then second distinctive difference is that we make the collaborative effort to correct this problem. In Korea, that we have about 23 free counseling center, and then we have a 200 counseling center for adolescents, about 200 counseling centers for the healthy family. So in total, about 500 free counseling centers are in operation. And in National Park we have a special boot camp that help people to revive their mind and also to get free counseling. Yeah, in Korea, also the Christian community is helping by having dormitories in different settings to help people. And one of the biggest enemies among Christian community is not Buddhism or different religion, but it is a smartphone addiction. And then church pastor, a lot of people, they just bow down and pretend to pray. But in fact, a lot of people, they're using their smartphones for texting. So about, many different churches also got involved in fixing and correcting internet addiction. And there are 5 major mental hospitals also treat internet addicted people with medication. And I work at NIA, and then we provide a preventative program and then free counseling program, and then we just make many different articles and then pamphlets to distribute, and also every 3 years, all different 8 government bureaus, we work together to solve this problem that we are facing. And what we're trying to strive is, and adolescent, toddlers, and grown-ups, they're all getting the equal opportunity to just get the help they need. And that is our goal, to treat all who are in need of assistance. And in America, there's an NGO Restart, and that there is a very, very wonderful program, I was told. And there's a 45 days of a treatment that costs $170,000. And then parents have to provide for their children's addiction problem. But in Korea, that whether it's a 3-month or 6-month program, the government is providing the complete treatment. The scientific and then reasonable approach to solve internet addiction is important. And in Korea, that adolescents and the young population are not allowed to use the internet after 12 midnight. And then there are many, it became a controversial issue among the professionals. I believe that it has to be stopped one of these days. And recently, that we got involved in the brain studies. In China, that anyone who plays internet game more than 5 hours, and the item levels or the credits gets to be deleted. And any underaged kids going to a PC cafe, and then they take away the license to operate business. And in some places in China, that they just put their children into the military training. And I think that we all together to create the most positive way of treating people who are in need of getting proper treatment. Thank you very much.